Hello, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of ICOS, the International Cardio-Oncology Society. Today we present highlighted information from a recent webinar regarding the treatment of atrial fibrillation in patients with cancer. As we all know, atrial fibrillation is common in general, but there are some special considerations for our patients with cancer. Our presenter is Dr. Abdel-Qadir of Women's College Hospital in Toronto, Canada. Dr. Abdel-Qadir is a graduate of the University of Toronto and a prior recipient of the Young Investigator Award from the European Society of Cardiology Congress. Today's presentation has been edited to maximize the amount of information we can present. If you are not a member of ICOS, please visit the website and join this organization. Also, don't forget and sign up to attend the Global Cardio-Oncology Summit this September in Minneapolis, Minnesota, USA. You can sign up at gcos2024.com. That's GCOS2024.com. And now let's hear information regarding the treatment of atrial fibrillation in cancer patients.
The opportunity to speak to you today. So I'm going to speak about Afib, anticoagulation, and cancer, the web that they interweave together and how we can. But the relationship between Afib and cancer kind of goes beyond just beyond demographics. So in addition to older age and shared comorbidities, there's several things about cancer that can increase the predisposition towards developing atrial fibrillation. So in general, cancer, as we know, is a pro-inflammatory state, which can increase the predisposition towards atrial fibrillation. And as we all know, a lot of the treatments, a lot of the costs of getting cured for cancer leads to adverse cardiovascular effects and systemic comorbidity, which can increase the predisposition towards atrial fibrillation. Several cancers, particularly cancers such as lung cancer or mediastinal malignancies, come with surgeries that can lead to up to a 30% risk of atrial fibrillation. The course of cancer treatment can lead to hypoxia, metabolic disorders, electrolyte disorders, and pain, other things that increase autonomic tone and can therefore provoke atrial fibrillation. And finally, there's sort of rare circumstances where the cancer can directly irritate the atria, causing atrial fibrillation, or some malignancies can have perineoplastic manifestations. So for all those reasons, you wouldn't be surprised to identify that people with cancer have an even higher likelihood of atrial fibrillation than the general population. So from a cardio-oncology perspective, I think one of the things that we're interested in is how do cancer treatments provoke cardiovascular disease? And in this particular circumstance, it's a reasonable question to ask, are there cancer drugs that can provoke atrial fibrillation? So there was this nice review that was published in European Heart Journal, Cardiovascular Pharmacology, from Joe Ali Salim and Javed Mosleh's group. But in this study, they kind of went about it in two ways. They used the VIGI-based data set to conduct a disproportionality analysis to identify drugs that had higher odds of reporting atrial fibrillation compared to what you would expect from chance. And then they also did a literature search to identify drugs that were associated with atrial fibrillation to try and figure out which of these were new associations. And probably not surprised to realize that there are sort of several drugs that seem to be associated with atrial fibrillation. But when you kind of try to dig through the noise, they identified significant univariable associations for 31 drugs. And after adjusting for patient characteristics, 19 drugs still had significant associations with atrial fibrillation. So some of the most prominent ones here, so not a surprise to anyone here that looks after cancer patients, but ibrutinib was associated with the highest odds ratio for reporting atrial fibrillation. Other drugs seem to generally follow a particular pattern. So the other drug where there was a strong association was aldesleukin, which is an IL-2 agonist that is used in melanoma and metastatic RCCs. The other drugs that were associated with Afib seem to all be drugs that are associated with hematologic malignancies. BCR-ABL, third-generation BCR-ABL antagonists And then lenalidomide, pomalidomide, other drugs that are used for hematologic malignancies seem to have the strongest association with AFib. Okay, so we talked about two types of associations. So you're diagnosed with cancer, you get AFib immediately after. You're diagnosed with cancer, and then you get AFib many, many years after. Now, what about the opposite? What about the reverse association? So intriguingly, there have been several studies that have shown that if you are diagnosed with AFib, you have a higher chance to get diagnosed with cancer in the near future. And so much so that, an editorial that accompanied this study actually suggested that AFib may be a marker of occult cancer. So let's try and unpack this a little bit. So I'm going to provide examples of two studies that have reported this association. So this was a nice study. This was a nice cohort because it was the Women's Health Initiative cohort, so a very well-characterized cohort with long follow-up. So they took the subset of women who are free from AFib, cardiovascular disease, and cancer, and they followed them over time. And then they used AFib and cancer as time-varying covariates. So once you developed AFib, they looked at the likelihood of developing cancer, or if someone developed cancer, they looked at the likelihood of developing AFib. So what they identified was that AFib seemed to be a strong predictor for people subsequently getting diagnosed with cancer. So a hazard ratio of 1.48, and the risk was particularly strong in the first 3 months after being diagnosed with AFib. So once you get diagnosed with AFib in this study, you had a threefold higher odds of being diagnosed with cancer. Now, beyond the first 3 months, there was still a strong and significant association, but it wasn't anywhere as strong as the first 3 months. Now, what about the reverse association? So the reverse association was similar to what we saw before. So if someone was diagnosed with cancer, there was a high risk of being diagnosed with AFib for the first 3 months, but beyond that, it wasn't really significant. So with that in mind, I think this is the guidance that we have from the ESC Cardio-Oncology guidelines, which essentially tell us to use the CHA2DS2-VASc score, even though there's this concern that cancer patients may have a higher risk of thromboembolism. And given the higher risk of bleeding, they actually emphasize treating people with class 1 indications rather than patients who have class 2 indications for anticoagulation. Now, when we looked at the literature, we kind of saw, we tried to understand this a little bit better. And definitely there were, studies that kind of supported a high risk of thromboembolism in people that have AFib and cancer. But there's an important caveat. Most of those studies did not adjust for differences in anticoagulation between the two groups. And we know anecdotally, and what's been published in a few studies, is that people with cancer and AFib are less likely to be anticoagulated compared to people who have AFib without cancer. Now, there's one study that did this, that's published in JACC Cardio-Oncology, but they didn't really adjust for anticoagulation. What they did is they treated it as a competing risk. So what that means is that in a time-to-event analysis, like when you censor someone, basically they continue to be at risk for the event. Just because you don't follow them, but basically anything else that happens to the population gets factored into the risk associated with that person. When you treat something as a competing risk, what essentially happens is you essentially say that this person becomes immune from developing that outcome. And when you do that in the setting of anticoagulation for AFib, where that happens more in people with cancer than others, what happens more in cancer-free patients, you're going to artificially lower the cancer risk in people who are more likely to have anticoagulation, who are people that were cancer-free. And then finally, there's also like a lot of subtle differences between people who have cancer and who don't have cancer. We may be missing some of these if we sort of just adjust. And so this prompted us to try and study this using some of the data that we have access for. So as I mentioned, we have the ability to identify everyone who's been diagnosed with cancer in a large province. And so we identified about 200,000 older people over the age of 66 who were diagnosed with AFib. And we looked back to see what was the difference between people who had a diagnosis of cancer recently within the past 5 years and those who didn't. And we found some interesting observations. So beyond the anticoagulation piece, we found there was another important difference, is that people who had AFib while having cancer were much more likely to be diagnosed with AFib while they were hospitalized. So we're talking about like provoked AFib that happens after surgery or after someone is hospitalized for pneumonia or after a stem cell transplant. Provoked AFib as opposed to AFib that's happening in ambulatory patients and that's chronic. And I think this has important implications because we know that patients who have AFib that's diagnosed in the setting of hospitalization is much less likely to be anticoagulated. And it was much more likely to be coded as a secondary diagnosis in cancer patients. So this was something that was also important to account for that we kind of hadn't really identified from the previous literature. So what we did is we took people with AFib and who had cancer, and for every person that had AFib and cancer, we matched them to someone who had AFib without cancer, was of the same age, was the same sex. We also made sure they had AFib diagnosed the same way. So if it was diagnosed in hospital in the cancer patient, it was diagnosed in hospital in the control. If it's coded as a secondary diagnosis in the cancer patient, we made sure it's coded as a secondary diagnosis in the control. And we also hard matched to make sure that every cancer patient was matched to a control that had the same CHA2DS2-VASc score, but also had the same atrial bleeding score. So the atrial bleeding score is a validated risk score for bleeding. It includes things like age, renal dysfunction, prior bleeding, hypertension, and I think it was liver disease. That's the last one I'm blanking out. Now we use the atrial bleeding score rather than HAS-BLED for two reasons. One is HAS-BLED kind of has labile INRs, which are not relevant in the area of DOACs. Then the second thing is actually hard to kind of determine how you define labile INR in such a large data set. But what we did here is we actually then made sure that we had a tighter match between people with AFib and cancer to cancer-free controls. And so we ended up with about 22,000 pairs, about 44,000 patients, half of which had cancer and half of which didn't. So an older population, predominantly male, and not surprisingly, even with this tight matching, we found that there was less anticoagulation in the cancer group, quite a bit less anticoagulation. And so therefore, when we followed for differences in the risk of bleeding and stroke, we had to make sure that we adjusted for anticoagulation as a time-varying covariate. So we kind of separately for the time when people were taking blood thinners and time when people were not. So what did we observe? So in terms of the risk of stroke, we found that there was absolutely no difference in the risk of stroke amongst people with cancer and cancer-free controls if you accounted for these things as carefully as we did. So if you look at the full cohort, the hazard ratio is 1.01. That's almost as close as you can get to unity. Now, when we limited the analysis to people who had a recent cancer diagnosis within the past year, the hazard ratio was still the same, 1.03. Now, we looked at people that had lower CHA2DS2-VASc scores because these were people who potentially may have an additional indication to anticoagulate because of the cancer. So these are people in whom we may potentially do things differently. Once again, there was no difference. Now, when we looked at all the specific malignancies, we found that in general, there was no increase in the risk of cancer for some of the common malignancies. Although the one thing that stood out was lung cancer, where there was a higher risk of stroke. Now, we don't know if this is real or whether this is a marker of incomplete confounding because we could not adjust for smoking. We did not have data on smoking, and smoking is more common in people with lung cancer. So it's something that pops out. So it could be real, could be perhaps some of the treatments that are being delivered for lung cancer, or it could be that these patients smoke and we just could not account for that. Now, when we looked at bleeding risk, things were a lot more heterogeneous. So in general, as we've seen in many other studies, being diagnosed with cancer was associated with a higher risk of bleeding. And this was slightly higher in people who had a cancer that was more recent, although confidence intervals overlap. Now, if you looked at malignancies, though, the most common malignancies that we tend to think of in the setting of cardio-oncology, breast cancer, prostate cancer, and lymphomas, were really not associated with significantly higher risk of bleeding. On the other hand, adenocarcinomas and myeloid malignancies were associated with a higher risk of bleeding, kind of highlighting an important point, which is, I think, also mentioned in the ESC guidelines, the fact that we should not really treat cancer patients as a homogeneous population, like they're not a monolith, but the bleeding risk is quite heterogeneous. And I think we have to think about not just the individual cancer at play, but also how that cancer plays out within that patient, right? So even within the setting of a GI cancer, depending on how small the tumor is, where it is in the GI space, is it involved in the endoluminal space or not, would have implications about the bleeding risk. So bottom line is it doesn't appear to be a higher risk of stroke when we tightly account for everything. There appears to be a higher risk of cancer with myeloid cancers and with adenocarcinomas. But these are sort of the key take-home points I wanted to leave you with. So, whether it's causal or not, there's a high likelihood for coexistence of AFib and cancer. So if you look after people with AFib, you're going to see lots of cancer. If you look after people with cancer, you're going to see lots of AFib. And once again, it may not be causal, but it likely is more than what you would expect just based on age and comorbidity. Now, what happens in the short-term period around cancer diagnosis? There's lots of noise, there's lots of competing things, and it's sort of hard to know whether this is causal or not, whether we just happen to be picking up more AFib in people who are sicker. What's intriguing, and I think an area that probably warrants more research and attention from the cardio-oncology community is there really an increase in the risk of AFib long-term, like beyond the 5-year mark in cancer survivors? And if so, is this related to treatment or not? And if it is related to treatment, is it related to cardiotoxic treatment? Or is it just like the wicked inflammatory milieu that happens when someone's being treated for cancer that sets them up for a higher risk of AFib? It would be highly relevant in our survivorship population because, as we all know, almost 70% of people diagnosed with a cancer now become 5-year survivors. There's this interesting story for reverse cardio-oncology. There may be something about inflammation provoking AFib and leading to a diagnosis of cancer, but another plausible pathway is that a new diagnosis of AFib may lead to anticoagulation, which may unmask bleeding. So I think an important point here is that when we see bleeding in people with AFib, there is a high likelihood that that may indicate a cancer diagnosis. It's important to work that up, particularly because it may allow us an opportunity to have the cancer diagnosed at an earlier stage where it may be potentially curable. And so, although bleeding due to anticoagulation is bad, this may be an area in which there may be a silver lining. When we think about treating people with AFib and cancer, I agree with what the ESC guidelines tell us. So I think we should still use the CHA2DS2-VASc score. And because the risk of thromboembolism doesn't seem to be independently increased in people with cancer in the setting of AFib. I'm not talking about thromboembolism without AFib or DVTs or PEs. But it seems like AFib increases thromboembolic risk to a certain amount that having cancer doesn't seem to change it that much. Now, there is higher bleeding risk in some, but not all cancers. So once again, kind of look at your patient and think about them. And then use the ESC guidelines. But in general, I do think that the guidance of prioritizing people with class 1 indications for anticoagulation rather than class 2 indications is reasonable. But ultimately, I think this really, one of the nice things about this, is just like a lot of cardio-oncology, right? It's really hard to kind of have prescriptive guidelines because our patients are all different. They all have different sets of circumstances, different things that contribute to their cancer risk, and different things that contribute to their cardiovascular risk. So I think this is really somewhere where we need to think about the art of medicine. We have to go back to being doctors and nurses and healthcare providers, and think about and make personalized decisions where we think about the person's risk of adverse outcomes, the benefit that may come from treatment, but also their prognosis from a cancer perspective. So that's all I have to say. Thank you for your attention.
I hope you found the presentation informative. Dr. Abdel-Qadir has provided us with a great conceptual framework to understand the demographics and mechanism of atrial fibrillation in cancer patients, while also giving us some practical tips for managing these patients in the clinical setting. If you enjoyed this, I know you'll want to attend the Global Cardio-Oncology Summit. There is still time to sign up and attend this premier meeting, which occurs in September 2024 in Minnesota. All the necessary information is available at GCOS 2024. That's gcos2024.com. Until then, we remind you to treat cancer, protect hearts.